Thanks very much. I'd really like to thank Dr. Shah and the Binaytara Foundation for this very kind invitation to be here. This is my second year, and I'm enjoying it even more than last year. So thank you. And when we think about secondary AML, we think about either AML secondary to antecedent hematological disorder or therapy-related myeloid diseases, and I'm going to really focus on therapy-related myeloid neoplasms. So these occur after prior chemotherapy, radiation, or a combination of the two, and usually have a latency period of about 3 to 8 years after exposure. And incidence is variable depending on various series, up to about 5% of cancer patients that you treat in your practice. There is a lot of data on this dating back to early 2000s. You see, this is a paper from Dr. Armitage that looked at this issue. And I think the most important thing is the incidence depends on the duration of follow-up and also how big the population you're looking at, and perhaps to the type of chemotherapy or radiation that the patients receive. But you can see on the right of this picture that the incidence is variable up to, in one series, to 20%, but I think that's probably an outlier. This is another study that looked at the incidence of therapy-related AML by years after initial chemotherapy during various time intervals in the various decades and according to different diseases. And you can see that in some diseases, for example, non-Hodgkin's lymphoma, there has been increased incidence of these therapy-related myeloid neoplasms. And again, I think I'd like to emphasize an important factor this is the length of exposure. So obviously, if your patients do really well and survive their primary cancer, they are much more likely to be at risk of developing their therapy-related diseases. In the same study, they looked at this by age of the patients. And again, that's another important factor in terms of length of exposure, because obviously if you have older patients, they have a shorter time period that can be exposed to develop the therapy-related myeloid neoplasms. This is a study from this is a study from German Hodgkin's lymphoma group, and you can see here they looked at the incidence of therapy-related myeloid neoplasms after receiving intensive therapy with their BA-COP regimen. And you can see even by the number of cycles of BA-COP, there's a significant difference in the incidence. The more intensive chemotherapy regimens, obviously the regimens particularly that include alkylating agents, the higher likelihood of your patients developing this. This is from Stanford. Again, over the years, they have been limiting the amount of alkylating agent they use in their Hodgkin's lymphoma patients, and also using better radiation techniques. And they also showed on the left the overall incidence of therapy-related myeloid neoplasm is significantly better in the more recent regimen. At the bottom of the curve, you can see it's almost none. And this is just looking at the incidence by their primary therapy. This includes the patients who relapsed and had further therapy with other agents. But if you look at the primary therapy, over the years, by reducing the exposure to alkylating agents and improving their radiation techniques, they're almost eliminating this problem in their Hodgkin's lymphoma patients. This data is from both Dana-Farber and MD Anderson, and this looked at patients who only receive radiation as opposed to a combined chemotherapy and radiation. And at least in this study, the patients who had radiation alone had a very similar outcome to de novo AML patients, and significantly better than combined chemo and radiation patients. Again, emphasizing the fact that there is importance of what treatment you're giving to your primary cancer patients and what would expose them to developing this secondary or therapy-related neoplasms. The characteristics of these patients have now been looked at by a number of studies. This is from University of Chicago in a relatively small number of patients, about 300. And they typically have high-risk cytogenetic abnormalities. I don't know if you can see this, but these are typically complex and chromosomes 5 and 7 abnormalities. But as you can see, you can get therapy-related APL or therapy-related core binding factor leukemias. So it's not impossible to have a patient with APL who has had prior typically anthracycline-based therapies. And there's actually a very nice study by David Grinwade that was published in New England Journal of Medicine showing a direct association with drugs such as mitoxantrone and epirubicin to developing therapy-related APL. But also, as this study shows, the outcomes are dismal. As you can see, survival for this population is not good. And this is from the German Hodgkin's lymphoma group study, again showing that although here the survival is a bit better, but still only about 30% of patients are alive long-term from their therapy-related AML. Another cohort of or population-based study from Denmark with some collaborators from Stanford looked at both secondary and therapy-related AML patients and compared it to the incidence to the de novo in the country of Denmark. This is national registry and so essentially a full compilation of all their AML. You can see the incidence of both therapy-related and secondary AML is lower, obviously, than de novo. And the primary cancers are obviously a group of different cancers, as you would expect, including lymphomas, breast cancers, and others. In terms of outcome, by cytogenetic risk, the outcomes for therapy-related patients and even secondary AML patients obviously is significantly worse. This is favorable, intermediate, and adverse risk patients. This is overall. De novo is blue, and they significantly have a better outcome. If you look at age, also younger patients, again, de novo is blue, and therapy-related and secondary are the yellow and red colors. In patients over 60, this distinction between de novo and therapy-related becomes a little bit more blurred. As you heard from Roland, this is a population of patients with AML over the age of 60 that even in the de novo setting, we have problems in terms of curing them. This is a study from one of the German cooperative groups, again looking at the therapy-related population. And you can see the distribution of cytogenetic abnormalities between therapy-related patients and de novo patients is very different. A much higher incidence of normal carrier type in de novo patients, and much higher incidence of MDS-related cytogenetic abnormalities, typically 7 and 5 abnormalities in the therapy-related population. There is a fairly similar distribution of the core binding factor leukemias, which to me was a little bit surprising, but again, you have to be aware that you can get inversion 16 or 821 or even APL after prior therapy with chemotherapy or radiation for other cancers. When they looked at patients who had at least one cytogenetic abnormality, so this excluded the de novo, you can see there is a high incidence of really bad characters such as complex cytogenetics or monosomal karyotype in the therapy-related population as compared to their de novo population. So clearly, this is a disease that per se has a bad biological characteristics, and this is why they tend to do significantly worse than de novo patients in terms of the long-term outcome. So the question is it just the fact the risk for these patients to develop therapy-related myeloid neoplasms, is it just based on their prior chemo and radiation, or is there some inherent features in the patients that may predispose them to this problem? And there are now a number of studies that have looked at various polymorphisms and mutations in these patients. And the question is, if we can try to identify those patients that you're treating for the breast cancer or lung cancer, etc., that may be more prone to develop these therapy-related myeloid neoplasm. Obviously, the sad truth is when these patients develop their therapy-related AML or MDS, they are potentially have been cured of their primary cancer that they saw you for initially. So there is a number of studies that now have looked at clonal hematopoiesis of indeterminate potential, and that's they looked at large population of quote-unquote healthy patients with or individuals without cancer. And they have identified a number of clonal mutations in these healthy individuals. And they have shown that the incidence of these mutations increases with age. And the presence of these mutations does predispose them to higher incidence of hematological cancers. Interestingly, in this the study from the Harvard group, the higher risk of mortality was related to cardiovascular mortality, not malignancy. But there is an increased incidence of hematological cancers in these normal individuals who have their clonal hematopoietic abnormalities in their blood and bone marrow. And obviously there are now theories that these mutations pre-exist in some individuals, and then for whatever reason they developed into obvious neoplasms such as MDS and eventually AML, as you heard, by a sort of clonal evolution and acquisition of secondary and tertiary abnormalities. This is somewhat similar to what has been described in myeloma. You heard about MGUS, and also in CLL there's clonal lymphocytosis of indeterminate potential. But one can appreciate that these individuals are individuals who are healthy, but they have these abnormalities that can potentially predispose them to develop their MDS or AML. And this is important in terms of therapy-related disease. This is a study from Washington University. They looked at 22 patients with therapy-related AML in their database, and they were able to look at their samples for presence of mutations. And interestingly, the overall number of mutations in therapy-related patients was not significantly higher than their de novo AML patients. However, they did see a significant increase in certain mutations. So, for example, a third of the patients in this 22 patient population of therapy-related AML had TP53 mutations. There were other mutations as well, but the significant increase was in the TP53 mutations. They had samples from 7 of these patients dating it to several years back, and they were able to show the presence of these mutations in some of these patients. So this was not just at the time of diagnosis of therapy-related AML or MDS. The samples that had been collected several years back did still have those mutations. And interesting, in 2 of these patients, they actually had sample prior any therapy for any cancer. So they had, these patients had lymphoma, but their samples were dated prior to initiation of any form of chemotherapy, and they still showed that they had the TP53 mutation. So the mutation predated any chemotherapy or radiation. And they did a mouse study as well, and they infused these mouse with p53 mutated hematopoietic stem cells, and they showed that when they gave these mouse nitrous urea, the p53 population expanded. So it was essentially a clonal advantage to have the mutation. So this leads to a hypothesis that these pre-leukemic clone may be present at least in a proportion of, or probably in a significant proportion of patients who develop therapy-related AML or MDS after they receive prior other chemotherapy for their prior malignancy. So potentially in the future, we can try to identify these patients at high risk, and potentially in the future, we may have strategies to try to avoid that. Dr. Koichi Takahashi is one of my colleagues who has looked at this at MD Anderson. He looked at 169 patients with therapy-related myeloid neoplasms diagnosed between this period. And he actually went to our epidemiology department, and there were blood samples in 14 of these patients prior to getting any therapy for their primary cancer. And he looked at these 14 patients, and he identified clonal hematopoiesis, various mutations in all of these individuals. But more importantly, in 10 out of these 14 individuals, these mutations existed at the time of the original blood sample collection prior to any chemotherapy. So he showed that at least in this small series, 71% of patients had evidence of clonal hematopoiesis with driver mutations in the peripheral blood samples taken at the time of primary cancer and prior to receiving any chemo or radiation. And I think this is important because, again, this may give us a tool in the future to try to look at these patients before we give them the chemotherapy or radiation for their breast cancer or lung cancer, and hopefully we may have strategies to try to reduce the risk of these therapy-related cancers. So the concept that we originally had that the chemo and radiation cause these mutations to eventually progress to AML or MDS is being re-challenged by this identification of these mutations prior to any chemo and radiation. These are patients at risk who develop cancers, and then you give them chemo and radiation, and this expands these populations to progress to therapy-related disease. Now, a few brief words. I know I'm getting short on my time on therapy, and as you know, treatment of these patients always requires allogeneic stem cell transplant. This is the data that was published a few years ago, looking at the outcome of patients who did or did not receive allotransplant, and significantly better for those who did get a transplant. And when they looked at the donor source, there was no statistically significant difference between sibling or unrelated donor, perhaps a little bit better for sibling donor. This data was published by Mark Litzo from the registry, and again looking at patients with therapy-related MDS or AML, and he was able to identify a number of factors that predicted or was relevant in the outcome of these patients. As you can see, there's, interestingly enough, higher risk of treatment-related mortality for MDS patients as compared to AML, even AML, more advanced AML, and higher incidence of relapse in patients with AML who were transplanted not in remission, and this is something that the transplanters have been telling us forever. That's not a big surprise. But interestingly, they looked at patients by a number of potential risk factors: age more than 35, presence of adverse cytogenetics, and type of donor being matched or unmatched, and the state of the disease, AML not in remission or high-risk MDS. And if the patients had none of these 4 risk factors, they tended to have a reasonable outcome. 50% of them were alive and surviving many years later, whereas if you had all 4 of these factors, the outcome was essentially dismal. Essentially nobody alive beyond 1 year. So this is an important thing to consider when you are referring your patient for transplant, because one would consider, I don't know if Dr. Rondelli would agree with me, if you have a patient like this, one would question the role of transplant, but unfortunately we don't have anything better to offer, so I think we will probably still send all of our patients. Now, what about other strategies? And I think this is the new thing that is going to probably change the arena, and this is CPX-351, which is a 5-to-1 molar ratio of cytarabine and daunorubicin encapsulated in a liposome. And preclinical studies have shown that this can penetrate bone marrow potentially better and is more effective in terms of getting rid of leukemic blasts. So with this in mind, initially there was a randomized phase 2 study which did a 2-to-1 randomization of all the patients between the ages of 60 and 75 and these are all comers, including de novo patients. And the primary endpoint was the response rate. They were randomized to either CPX-351 or the traditional 3+7. And the important thing that was shown in this study, the overall, there was no difference, but in the patients with secondary AML, which included therapy-related as well as patients who had prior MDS, there was a higher response rate, close to twice as many responses, and a better overall survival and event-free survival. If you look overall, the difference was not significant, but for the secondary AML patients, there was a significant difference. And this is why the sponsor actually designed this phase 3 trial that randomized patients now 1-to-1 to receive either CPX-351 or 7+3 for their initial AML therapy. These were patients between the ages of 60 and 75 years, either had therapy-related AML or AML with history of MDS, with or without prior hypomethylating therapy, or history of CMML. Important to know is that patients with history of myeloproliferative disorder were excluded. So please don't extrapolate this to patients who have myelofibrosis and develop AML. And then also they did include a group of patients who had de novo AML but with MDS-related karyotype. And they would receive 1 or 2 cycles of induction. If they achieved a response, they would have consolidation and they would be followed up. This is the regimen. That 3+7 is what many of you used. First induction, both groups could have 2 cycles of induction. The second cycle of induction, as most of you do, is 5+2, and the consolidation were also 5+2. The CPX-351 was given initially for 3 days for the first induction, the same dose of 100 units per meter squared for 2 days only for reinduction or second induction if it was needed, and then the consolidation was a lower dose for 2 days. And 2 groups, as you would expect from these randomized trials, were very well balanced and well matched in terms of their pre-treatment characteristics. And they did meet their primary endpoint of survival. There was a significant difference in overall survival in favor of the patients who had CPX-351 as opposed to the 3+7 regimen. In terms of event-free survival, there was a statistically significant advantage for CPX-351. And in terms of response rate, again, you can see that if you just look at CR, there was an advantage, which was statistically significant. And if you brought in the CRI into it as well, again, there was a significant advantage for the CPX-351. Importantly, the early mortality was not worse for CPX-351. The 30-day mortality was, if anything, better. And if you look at 60-day mortality, again, it was better, mainly because the responses were higher after the 30 days in CPX-351. The green boxes are the patients who died because of progressive disease, and you can see significantly higher in the 3+7 subset. Adverse events were very similar, myelosuppression-related adverse events. Importantly, there is no non-myelosuppressive particular adverse event related to CPX-351. And if you look at count recovery, it's a little bit later for CPX-351. This is ANC recovery. You can see a few days longer. And platelet recovery also a few days longer for CPX-351. And so this drug is myelosuppressive, and you obviously have to be careful of that in your patients when you do and give them full support. Actually, higher number of patients on the CPX-351 were able to go on to allogeneic stem cell transplant, and obviously that's important because, as I mentioned, this is a standard of care for these patients. And when they looked at outcome censoring at transplant, now the p-value disappears, but still the advantage is for CPX-351. But when they did a landmark analysis at transplant, here you can see a significant advantage for CPX-351. So I think many of us in the AML world believe that this is going to be a drug that will be approved in the next year, and it would actually hopefully improve the outcome of these patients to some degree, at least perhaps by allowing more of them to go to transplant. So in my conclusions, therapy-related myeloid neoplasms and AML particularly are less responsive to traditional strategies. It is important to try to focus on this clonal hematopoiesis and these driver mutations that can predate prior chemo and radiation for other cancers, and maybe are potential risk factors for development of therapy-related neoplasms. And as I mentioned, maybe sometime in the future we will have specific strategies for these patients. Allogeneic stem cell transplant continues to be the standard of care, and CPX-351 is likely to become a potential future strategy for your patients who do have this disease. Thank you very much again, and I appreciate your attention.